So I call upon Dr. Anu Joseph for her presentation on 2 cases of Flecked Retina. Dr. Anu Joseph is a medical retina consultant at Lisi Hospital in Kochi. Over to you, Anu.
Thank you, Natasha ma'am, for giving us this wonderful opportunity. A very good afternoon to all. Okay, going straight to my cases. Case 1 was a 19-year-old male who was referred from our nephrology OPD with a recently diagnosed acute on chronic kidney disease, and he was initiated on hemodialysis. He had a bilateral sensory neural hearing loss for which he is on hearing aids since childhood, and he has recurrent asthmatic attacks. His best corrected visual acuity was 6.6 in both the eyes. He did not have any complaints of defective vision or headache at the time of presentation. Anterior segment examination, both eye cornea was clear, pupils were 3 mm reacting to light, and the lens was clear and normal in shape. Dilated fundus examination, both eye, the media was clear, the disc was normal in size and shape with a normal cup disc ratio, but there was a generalized arteriolar attenuation, and the macula showed some yellowish dot-like flecks sparing the fovea with a single dot blotch hemorrhages and a lamellar hole. The retina was on, the macular reflex was however dull. So this was a fundus picture of the right and the left eye of this boy, and taking a closer look at the macula, we can see the yellowish dot-like flecks surrounding the fovea with the red arrow pointing at the lamellar hole and the dot and blot hemorrhage. This was the OCT macula of the same patient, showing the very evident lamellar hole, and the left eye had a small vitreomacular traction. So taking into consideration his progressive renal failure, hearing loss since childhood, and the retinal abnormalities, we came into the differential diagnosis of most probably an Alport syndrome and less likely to be an IgA nephropathy. So Alport syndrome has been reported in 1 in 10,000 individuals, where 3 times the males have more preponderance. And the diagnosis is important. Why? Because the risk of disease in other family members and an early treatment with ACE inhibitors in such patients can definitely delay the onset of an end-stage renal disease. So genetic mutations linked to collagen 4 has been pondered into, which can be either X-linked or autosomal recessive. This leads to an absence of collagen 4 from the basement membrane of different structures of the eye, including the cornea, retina, etc. So there are features which do not affect the vision, like corneal opacities, anterior lenticonus to a little extent, and then flecked retinopathy, which can be either central or peripheral, staircase fovea in the form of vitreomacular traction or a mild foveopathy, and temporal retinal thinning. Among this, anterior lenticonus and flecked retinopathy are more in favor of Alport syndrome. And those which affect the vision include posterior polymorphous dystrophy of the cornea, a giant macular hole, bullseye or vitelliform maculopathy. So why are the ophthalmic features important? Because it gives us an idea of the mode of inheritance. Peripheral retinopathy in a mother of a male with hematuria gives us a clue about X-linked inheritance, whereas a central retinopathy or lenticonus is more in favor of autosomal recessive. So the management of ophthalmic features, lenticonus, the child will have frequent changes of prescription lenses, which will finally lead to a lens removal that can give us a solution. But the macular holes in Alport syndrome, however, respond less well to the surgical closure. So gene therapy is also being under study for the reversion of the causative collagen 4 variants. So that's all about my first case. And coming on to the second case, we had a 29-year-old female. She was a nurse by profession, presented to our emergency department with high-grade fever with chills for 4 days, headache, and 1 episode of vomiting. She was febrile, and her BP was towards the lower side. Pulse rate was 86 per minute. Her other systemic examination was within normal. Lab investigation showed that she was positive with a dengue serology, and her platelet count were very less, like 40,000 per millimeter cube of blood. She was started immediately on IV fluids and admitted in our hospital. The next day, she developed a sudden onset painless loss of vision in both her eyes, and she was referred to our side. Her vision in both the eyes were 6/60, but it was definitely getting corrected to 6/5. Near vision was normal, color vision normal, and intraocular pressure was near to normal. Anterior segment examination was also normal. And this was how the fundus looked like of both the eyes. Taking a closer look at the macula, we could see some crinkled paper-like appearance around the fovea, more of an kind of ILM folds. This is a red-free imaging showing it a little more prominently. So this was a OCT scan of both the eyes. We can see the highly reflective ILM folds with small irregularity, and a localized vitritis could be seen more prominent in the right eye compared to the left eye. So we came into the probable diagnosis of dengue fever-related maculopathy or a post-viral maculopathy. So dengue-associated maculopathy, the first case had been reported in the late 1980s. The maculopathy can cause a mild, even to severe visual impairment. The delay of the ocular manifestation from the onset of the systemic dengue fever always gives us a clue about the autoimmune-mediated cause. So most of the cases are self-limiting. 10% of hospitalized dengue cases have found to have this. So conservative immunosuppression can be started based on the visual acuity. Resolution in bilateral cases, however, may not be symmetrical. So the visual recovery corresponds to the improving platelet counts. 0.5 to 1 milligram per kilogram per day of oral prednisone has been advised in certain articles, but in our patients, oral steroid was totally contraindicated from the physician side. So she was started on topical prednisone 1%, and we could see an immediate restoration of normal vision to 6/6 without any refractive correction on the next day. But the fundus picture did have some remnant changes. So some retrospective study at Singapore have shown the use of immunosuppressive agents. It is difficult to determine whether the good visual outcome is a result of our treatment or is a part of the natural course of the disease. So a prospective randomized clinical study is definitely necessary. So thank you everyone, and these are the queries to my panel. How effective is ILM peeling in early macular traction changes at the fovea in Alport syndrome patient? And second, next were related to the dengue maculopathy. When to start oral steroids in a dengue positive patients with decreased vision? Is there any cutoff limit for vision? And secondly, is dengue maculopathy related to the serotype of a dengue virus or any secondary attack in the same patient?
Thank you, Dr. Anu. That was two wonderful cases. Since they are completely different cases, we'll take them one by one. Let us first talk about the Alport syndrome. Did your patient have any history of night blindness? Did you ask?
No, ma'am. No history of night blindness.
No history of night blindness.
He did not have any ocular complaints per se.
No, but specifically night blindness, sometimes they will not notice if it's very mild.
No history of night blindness.
So, and also, what were the differentials that went through your mind when you saw the flecks in the retina?
It can be a variant of retinitis pigmentosa. Then taking into consideration his renal failure, so we were more into...
So it was easier for you to diagnose because the renal failure was already there.
And he had sensory neural hearing loss too. He was on hearing aids.
Okay, but that again can confuse us because we can think of sensory neural hearing loss with RP, which would be like conditions like Usher's. But with the central flex and sensory neural hearing loss, something else that we might consider in the differential diagnosis will be congenital rubella.
Okay.
Because that will have the salt and pepper retinopathy in the center with sensory neural hearing loss. So we have, when we have flecked retina, we have so many different differentials that we can think of. I suppose the way to go about it would be first to look at the vessels, because retinitis pigmentosa, the vessels will always be narrowed, whichever variant it is, sign pigmento or otherwise, or one of the systemic associations, all of which will have arterial narrowing as the basic feature. So if that is not there, then we can be sure that it is not retinitis pigmentosa variant. Then we have the flecked retina with normal retinal blood vessels, which also have night blindness, which will be your congenital stationary night blindness with flecked appearance. So that is fundus albipunctatus. The other things that again have a flecked retina but and may have night they don't have night blindness is like congenital rubella. The only association with renal disease is Alport's. Of course, the finding that you should look for in the lens is whether there is an anterior lenticonus. And as you all know, the mnemonic is also easy to remember, Alport's anterior lenticonus. So that is also easy. Here the diagnosis was easier retrospectively because the patient already presented with renal failure. But when a child comes to you, these are the things that we can think about when we look at a flecked retina. Dr. Sunil?
What was the vision in the first case?
6.6.
So that points that we need not go for any intervention because when it's not a full thickness macular hole. And though you are told there is retinal attenuation, the fundus picture did not show that much of attenuation. That was what I felt. Okay. And fundus albi means punctata albicans, retinitis punctata albicans would have a more attenuated appearance, and I feel that the visual acuity should have been lower than.
Yes.
Lower down. And rest of the flecked retina syndrome, like fundus flavi maculatus. See, the primary feature of fundus flavi maculatus, there will be flecks near the macula. There will be, you can see the flecks, but the visual acuity will be lesser. Stargardt's fundus, it's a combination.
Yes.
Or you can have a fundus albipunctatus that can have a consider that flex will be more diffuse, more diffuse, and congenital drusense, but that also is out of question. So as far as I am concerned, I think I will not intervene in that case. Okay.
So generally, these degenerative retinal diseases have poor prognosis for macular hole surgeries. Most surgeons will steer clear of doing any surgeries for them. Fundus flavimaculatus, like Sunil sir said, is an important differential, but it is one of these, it is in the spectrum of hereditary macular dystrophies rather than the retinal dystrophy. So it will definitely be symptomatic and they will have decreased vision. Okay, now we'll go on to discussion of the second case, which was dengue foveolitis.
Yes, ma'am.
Do you have any experience with it?
Did your patient have any drop in platelets?
Yes, ma'am. It was in the lower side. 40,000 was at the time of presentation.
Okay, there are no symptoms of that platelet like hemorrhages or anything in the fundus?
No petechial hemorrhages.
Only thing I wanted to, maybe if you could do an FA and maybe we could see what exactly any vasculitis or anything is happening in the macular area.
Okay.
Because when there was an epidemic of dengue some time ago, we had a series of cases and most of them had a slightly different presentation. They had this cotton wool like lesions at the macula with a serious drop in capillary non-perfusion areas were seen in the foveal vascular zone.
Okay.
As such, that time also we had written a lot of literature, but there is no recommended treatment. Whether to start oral steroids or whether not to start oral steroids is still controversial.
Okay.
Maybe an FA or some other imaging would give us a little more idea was what was exactly happening to this patient. What happened after? Did she recover vision?
Yes, after starting topical steroids, we had put her on a daily vision monitoring. So the next day it improved to 6.6. Don't know if it is due to the effect of topical steroids or a natural course of the disease.
Yeah, it is an immune reaction that happens.
Yes, ma'am.
That is what is a
it looks like that. There was a localized vitritis. It was not much evident in the anterior face. In the OCT, it was little evident. Just above the fovea, we could see some shadows.
Yeah, good cases. Yeah.
Just one question. In that, did you do a fluorescein angiogram?
No, ma'am, because she was little.
And she was improving with minus power to 6.6.
Yes, ma'am.
So she was a myope before also?
No history of any refractive error.